Good evening, everyone. We welcome you all to Ortho TV Hand Surgery Special Webinar Series. And we are live now, and you can go ahead.
So at the onset, I would like to welcome everyone those who have joined us this evening. I would want to thank our mentors, namely Dr. Ravi Bhardwaj and Dr. Pankaj Ahire, who have helped us putting together such a thoughtful program. Finally, I would want to thank Dr. Ashok Shyam, Dr. Neeraj Bijlani, and Rahul Choube, who have given Ortho TV platform for giving life to this program. Faculty for today are would be Dr. Pankaj Ahire and Dr. Parag from Mumbai, Dr. Praveen Bhardwaj from Coimbatore, Dr. Vijay Malshikare and Dr. Warid Altaf from Pune, Dr. Amit Varade from Nashik, and myself, currently from Kolkata. So, from the program's point of view, we would be starting off with evolution of understanding of the disease, uh, followed by decision making and controversies in the of the disease, and closing. Case discussions and closing remarks. So, without further ado, we would want to dive into the academic program, starting with the evolution of the understanding of the disease. So, can I share my screen, sir? Can everyone hear me? Should I start?
Yes, please.
So, yeah, so evolution of understanding of Keinbock's disease. So, the disclosures are regarding this presentation and have been made from the concepts taken from this monogram book. So, what we understand as a reason for Keinbock's disease presently is the morphological factors of like the shape of the lunate, radial inclination, and ulnar variance. So the individuals having a trapezoidal shaped lunate, a flattened radial inclination, and a negative ulnar variance, all in all causing an uncovering of the lunate, quite mimicking the Perthes disease. So what we already know also is the vascular factors of an absent dorsal anastomosis and an I-shaped pattern of blood supply that is at a risk to develop Keinbock's disease. However, current consensus is in favor of venous channels that are running parallel to the weight-bearing surface of the lunate. So it starts off with a stress fracture. It causes a localized venous hypertension. These changes propagate further, causing a compartment syndrome. This is because of the pressure gradients of the arterial and venous outflow. So, and marrow changes subsequently happen, and that triggers an inflammatory response, and which further leads to the lunate causing a lunate fossa of the radius causing an indentation of the lunate bone, and the capitate bone from above compressing the lunate from causing a nutcracker effect, and then subsequently causing carpal collapse and progression of the disease. Now coming to the age-related understanding, what the current consensus is that teenagers seem to have a better prognosis. This patient has a morphological and remodeling of the lunate bone. And now this term has been coined as Keinbock's disease. So as per my understanding, evolution lies under two headings. One, the understanding the etiology of venous hypertension causing compartment syndrome leading to a stress microfracture and a nutcracker effect on the lunate and carpal involvement. And second, the way healing occurs in teenagers. Thank you.
Do, do you want me to start my presentation?
Yes, sir. So the next
Yeah.
presentation would be on radial short. So we are combining radial shortening when and how and uh, uh, decision making in Keinbock's disease. So Dr. Pankaj Ahire, sir, can start now. Start
Yes, please.
sharing his screen. Yes.
Yes. Good evening, everyone. My brief was to talk about the treatment algorithm and then to talk about the joint leveling procedures. I just thought it appropriate to combine the two, else there would be a lot of overlap. So let's start with the question of when, and that will eventually take us to the algorithm. Briefly, this is how your most Keinbock's disease would present at different stages of their disease. Initially, there would be a just pain and the X-ray would be normal. This typically is a stage of ischemia and there may not be any radiological changes. At this stage, there may even be a fracture which is not visible on X-ray because essentially there is no collapse. The lunate architecture is intact. All articular surfaces are intact. This is how the MRI picture would look with X-ray being normal. Slowly, this would progress to a lunate which is dense. The pain continues. At this stage, fracture is very common. However, the lunate is still holding its architecture and there is no collapse. All articular surfaces are intact. This is how the X-ray would look at this stage. There would be a dense lunate. As the fracture progresses and the ischemia persists, the lunate collapses. The capitate starts driving into the lunate. This is a stage. This is called a stage of fragmentation. At this stage, some swelling on the dorsum of the wrist might be visible. The, Depending upon the amount of collapse and the status of the scapholunate ligament, the scaphoid may or may not flex at this stage. Because of the collapse, the lunate surface becomes irregular, and there may even be early radiolunate arthrosis. This is how the X-ray would look at this stage. So there is some early radiolunate arthrosis. The capitate has started driving into the lunate. Just to give you an example how a scaphoid flexes under lunate compression. This is the lunate which is compressed and this is the scaphoid. As against, this is the normal appearance of the lunate and the scaphoid. You can see that from this X-ray to this X-ray, you can see that the scaphoid is flexed and the distal pole of the scaphoid and the proximal pole of the scaphoid overlap, giving rise to a signet ring appearance like this. This is an indication that there is an advanced collapse that is happening. And then at this stage is when you start getting pain, swelling, and restriction of movement. Also, because there's a arthrosis between the scaphoid and the radial styloid. And slowly a pancarpal arthritis develops. Pancarpal arthritis is not very common that you see in Keinbock's because I'm yet to see one in my practice. So what we have just seen is the famous Listman staging of this disease. This is the stage 1 intact lunate, stage 2 fracture but no collapse, stage 3 collapse with scaphoid aligned, stage 3 collapse with scaphoid flexed, and pancarpal arthritis. This is a textbook picture. I don't have a clinical photo. So what we have seen now is when the lunate architecture is intact and there is no carpal collapse, which is the stage 1, stage 2, and stage 3, and even sometimes stage 3B, we would group it here. We would call it an early Keinbock's disease. When there is a carpal collapse and carpal arthritis, we would call it a late Keinbock disease, stage 3B and 4. This early and late helps us define the further treatment algorithms. What is important further information that is important in order to plan a good treatment is assessment of articular surface, and for which a CT and an arthrogram, a CT with arthrogram or a good quality MRI is valuable. Arthroscopy is now virtually becoming a gold standard for anything that is affecting the carpus, and so it is in lunatomalacia, as Dr. Amit Varade will take us through this. So that is, and what with introduction of arthroscopy in grading and staging of Keinbock disease, it brought us to a few variants in the classification proposed by Greg Ben from Australia. Now there is a Bain and Leishman's classification, which has virtually replaced the old Leishman's grading staging of this disease. Here too, we can classify those stages in which the lunate shape is intact as early, and those stages where there is a radial arthrosis as late. So essentially meaning, irrespective of all the information that you have in your hand, there are two factors that you need to look at. Is the lunate shape in normal, or is it a lunate which is constructible, or is the surface on which the lunate is going to glide onto the radius, how good is that surface? These are the two most important factors. Depending upon these factors, you have options of either saving the lunate or excising the lunate. How do you save the lunate? You decompress the lunate by various means, or you revascularize the lunate if it does not require decompression. If you feel the lunate is not salvageable, as in we saw late Keinbock disease, the lunate is fragmented, not reconstructible, that is when you might need to consider salvage, either a proximal carpectomy or a limited carpal fusion. So for lunate decompression, when is it possible? As I said, architecture has to be intact, there should be no carpal collapse, and the radial articular surface has to be normal. In such patients, if you have a ulnar variance which is negative or neutral, that is, if the ulna is shorter or at same level as the radius, then you might consider joint leveling procedures. If the ulna is longer than the radius, then obviously radial shortening joint leveling procedure is not going to work. At this stage, you might consider capitate shortening in order to decompress the lunate with third CMC joint fusion. You might want to add a vascularized bone graft, either a vascularized pisiform transfer. This is not a bone graft, it's a pisiform transfer which replaces the lunate, or the fourth extensor compartment artery vascularized bone graft. Or you always have an option of lunate excision and performing a proximal carpectomy or a limited carpal fusion. So this is an example of a negative ulnar variance with lunatomalacia. This would perhaps be stage 1. This patient also had early signs of scapholunate dissociation. She underwent a radial shortening. This was almost 15 years ago, and she continues to do very well. She has a yearly follow-up, and her scapholunate dissociation has not progressed, her pain has not progressed. This is another case. There is obviously a compression of the lunate. There seems to be some amount of fragmentation, no scaphoid flexion, and there is a neutral variance. How do you deal with such case where there is a neutral variance? So before we go on to this case, let's see how will we do a radial shortening. How the joint leveling is to be done. So there are two ways of doing joint leveling. One, we could lengthen the ulna, or we could shorten the radius. Of course, in radius too, there are multiple options. There is a step cut osteotomy, there is a coronal plane osteotomy, there is a metaphyseal osteotomy, and what I prefer is a diaphyseal osteotomy. It's almost always a transverse osteotomy, 2 millimeter wafer, and it is done through a volar approach. This is how it is done. This is the same example of the first patient that we saw. As you can see, there's a negative ulnar variance. As a first step, which 6-hole osteotomy is 6-hole 3.5 plate is applied, either locking compression plate for a transverse osteotomy. If you have an oblique osteotomy, then you would choose a 7-hole LCP. The plate is applied on the intact radius. Only the distal 3 screws are passed. At this stage, the level of the osteotomy is marked with respect to the 3rd screw from distal to proximal. At this stage, a vertical line is drawn just next to the plate. This line ensures that when we do the osteotomy at the level of the yellow line that you can see on the X-ray, we do not cause any rotational malalignment. It is much easier to rotationally malalign the radius than we think. So it's much better to take these preemptive steps. At this stage, the plate is now removed, and then what you are left with is these 3 holes of the screws, 1 vertical line and 1 transverse line. This is the time to plan your osteotomy at the previously marked line, and a 2 millimeter wafer is marked, and the 2 millimeter wafer is removed using a saw. There are multiple ways of doing this. The moment this wafer is removed, now the joint can be leveled. The vertical line ensures that there's no rotational malalignment. At this stage, you bring the plate back in and exactly put it where it belonged before, and finish the fixation and put the screws in compression mode, thereby compressing the osteotomy. This completes your radial shortening. Now let's get back to the same case that we discussed before. This is a case with a neutral variance. I would, without any hesitation, do radial shortening even for a neutral variance. This is how the wafer was cut, and that is the wafer that comes out, and a plate is applied volar side. After this, we take a dorsal approach and do what is called as a 4th extensor compartment artery. So this is where your wrist is. This is the forearm. This is we will be taking a bone graft based on this artery over here, and this is the 4th extensor compartment artery, and this Y bifurcation is used for lengthening the graft. So this vessel will be cut here, and then we'll take a vascularized bone graft based on this. That is how the vascularized bone graft has been harvested. That is the lunate. A trough is made in the lunate, and this bone graft is inserted. You can see this pedicle going and inserting into the lunate, and this is how it was done. You can see this bone graft that is inserted, and to prevent compression of the lunate, a scaphocapitate wire is passed. This is how exactly it would be done. Now, when would you not do a radial shortening? If there is a type 1 DRUJ, you are fine doing an radial osteotomy. If there's a type 2 DRUJ, what do I mean by type 2 DRUJ? In type 1, the two articular, the radial, the sigmoid notch is parallel to the ulna. In type 2, the sigmoid notch tilt towards the ulna. In this case, if you do a shortening and the radius comes down, then there's going to be an impingement in the DRUJ. So you would not do a radial shortening osteotomy when there is a type 2 DRUJ. When the radial articular surface is inclined away from the ulna towards the radius, you are all right to do a shortening. So you should be particularly careful in not shifting the focus of pain from lunate to the DRUJ by doing an osteotomy in not the right patient. Occasionally, you will have a positive ulnar variance and a Keinbock's disease. These perhaps are the candidates for a very early proximal low carpectomy. and Parag will talk. Praveen will talk more in details about this. Occasionally, you do get stumped. As you can see, this is 2009, 11 years ago. This lady had come to me with lunatomalacia. She was diagnosed and she was advised a lot of blah 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 depending upon our algorithm. For some reason, she did not undergo surgery, and for some other reason, she happened to come to me again after 11 years almost. This was her picture. The lunate continues to appear dense. There is some flexion of the scaphoid, but absolutely painless and completely functional wrist. And she had a question as to if she continues to enjoy such good range of movement 11 years on after she was advised a certain procedure to prevent wrist arthrosis and advanced collapse. How come she's enjoying this range of movement? So this is her current MRI. Doesn't look very bad. It though there is some signs of articular cartilage thinning. So I'm still unsure what exactly works in Keinbock's disease. One thing I will definitely tell you, I haven't operated twice for any patient of Keinbock disease in my entire career, which is now spanning about 2 decades. And until I know what definitely does not work, I intend to continue doing what seems to work. And that is, I would do diaphyseal axial shortening. I will do vascularized bone graft for neutral ulnar variants. I will combine it with radial shortening. I might do just the vascularized bone graft for a positive ulnar various patient, or even in these patients, I would consider early PRC if I find that the lunate is not salvageable. Thank you very much. Over to you, Karan. If there are any questions, I can either take them now or I can take them during the discussion. Thank you very much.
That was a very nice presentation, sir. We would be taking the questions in the end. So we would move on to the next presentation.
Thank you very much.
Yes, sir. So next would be how and when proximal row carpectomy by Praveen sir. So Praveen sir can start sharing the screen.
Is it visible? The screen is on?
Yes, sir.
Okay. Good evening, everyone. I'll be talking about proximal row carpectomy, one of my favorite topics when it comes to Keinbock's disease. So thank you, Karan, for not giving any other difficult topics to me. And it is quite easy to talk on when and how. So most of the times when you see a patient with Keinbock's disease, most of the times you'll be doing a proximal row carpectomy. So when you read about proximal row carpectomy, it is almost 110 years since it was described, but still we are not sure the treatment, what we are doing, what we are aiming at, and what is the outcome of such treatment. All the literature reviews have found no one treatment superior to other one. So from that, to me, the conclusion comes is we should do the simplest operation, which is simple for the patient and simple for us, which has the least amount of complications. Also, the literature supports this kind of view. So if you go through any survey of what is the best option for Keinbock's disease, this is one of the article in 2015, which assessed the options of all the American Society of Hand Surgeons about Keinbock's disease options. So if you see in general, when the 3A is the watershed. So anything below 3A stage, as you have already told about the grading of the Keinbock's disease. So till this stage, there is no carpal collapse. So all the reconstructive options are quite acceptable here. But after 3A, that is 3B onwards, you will require salvage operation. And this is the place where proximal row carpectomy has main role. Though there are different options like partial wrist fusions or PRC, but the surveys say that the PRC is the number one among choice of all the surgeons who treat Keinbock's disease. And this is the kind of graph you would see about the options of treatment, and PRC remains the boss. So in our practice, we have seen 91 cases of Keinbock's disease over 14 years. And not a surprise that almost 70% of them have undergone proximal row carpectomy. This is a very interesting point, and Dr. Pankaj also mentioned this. Most of the times, patients report to us when the lunate is collapsed, because that is the main symptomatic stage. And since the lunate is collapsed, at that stage, most of the times you will be required to do a proximal row carpectomy. So this is the treatment algorithm what we follow. I am not going to talk on that because it is very much similar to what Dr. Pankaj has told, except for a few small differences which we'll be talking about later. So basically, stage 3B and 4 are the cases in which we will require to do a proximal row carpectomy. Stage 4, though theoretically it means that there is a panarthritis, but you will hardly see a patient who has panarthritis, and most of the times you would be able to escape with PRC or some modification of it, as I will be talking about. So 3B and 4 are the main indications for doing proximal row carpectomy. This is the first part of my talk, when. So proximal row carpectomy in all the cases of 3B and 4, and 3A may be negotiable patients depending on patient's profile, his age, and their preferences. Now, why it is so popular in our hospital, why we like it so much is because the results are fascinating and they are very simply good result, and patients have to get back to work within 1 month. And once they are back to their activities, usually they can continue any sort of physical activity, including manual labor, though theoretically it is told that it is not a good operation for people involved in manual labor work. But we have seen most of our patients are doing hard work and they are able to manage their activities quite well. So this, you can see, this was the first proximal row carpectomy I had assisted after coming to Ganga Hospital. And this patient was 3B, fractured lunate, totally collapsed. And we have done a proximal row carpectomy, and this is his outcome at 10 years. And it is almost 13 years since the operation, but outcome at 10 years was so amazing. You can see full extension, full flexion over there. Not all the patients get this kind of good result, but most of the patients would have 70% range of movement and 70% grip strength. And that range and the strength is enough for them to do activity of any level. Again, there is long-standing controversy between proximal row carpectomy and limited wrist fusion, though personal choices can never be defeated. If you say I like it, so that we have to agree on to that. But all the comparative studies have found that proximal row carpectomy scores much over limited wrist fusion in all the aspects. Its conversion to a total wrist fusion, patients complaining of pain, range of movement, and complications which could happen after either of the two operations are much better in PRC than with partial wrist fusions. Though there is always an apprehension that the PRC is not a perfect machine and it is going to go for arthritis, but it is very nicely told, a malfunctioning machine is worse than a easy functioning better machine. So PRC converts a complex wrist which is not working properly to a simple wrist which will work properly and painlessly. To our good surprise, we have never required to convert any of the PRCs to total wrist fusion in 25 years. In Keinbock's disease, the proximal row carpectomy technique is quite standard, in which the proximal 3 bones are removed, the scaphoid, lunate, and the triquetrum, and the capitate is put onto the lunate fossa. And we have to be very careful about preserving the radioscaphocapitate ligament, because this is the main stabilizer of the PRC, and we should make sure that we have preserved this ligament. One important point is, when you are doing a PRC in a Keinbock's patient, we need to be very careful because of the avascular lunate could have damaged the lunate fossa of the radius. Now we know that lunate fossa of the radius is the one which capitate is going to articulate. If the base is not good, then the result may not be nice. And we have seen that in 21% of the patient whom we plan to do PRC, we ended up doing something else. And I will tell what is that something else. So whenever you are doing a PRC, think you should be prepared for doing interposition proximal row carpectomy or a scaphocapitate fusion, which Warid is going to talk about, but you will never require a total wrist fusion. So basically, when discussing with patient, we can tell that we are going to get you a mobile and pain-free wrist by two different techniques, either by proximal row carpectomy or partial wrist fusion. Take a good long capsular flap. So in case you find that the articular surface is damaged, this capsule can be interposed in between and it will act like an interposition material. And one other important technical point is don't excise the scaphoid before you see this articular surface. Because if you have excised the scaphoid, then you lose option of doing a partial wrist fusion. But if you have preserved the scaphoid, you can, and you find that the lunate articular surface is not good, you can convert into a partial wrist fusion, as Warid is going to talk about. If lunate fossa is good, capitate is good, PRC is the best. It will give a very nice result and very quick result. In 4 weeks itself, patient can get back to its normal activities. If the lunate fossa is not good, you could either do a scaphocapitate fusion or you could interpose the dorsal capsule in between. I think younger patients, scaphocapitate fusion is okay, but a patient who is anything more than 40, though I am also more than 40 now, but still I feel for anybody more than 40, PRC is much better. So the capsule is interposed in such a way, and it will give good 50% range of movement and a painless wrist. This is the result at 3 years post-surgery. Patient is quite comfortable and doing all the activities. So to summarize again, when to do a proximal row carpectomy, that is the stage 3B and 4 for sure, and 3A in some select patients. With that, I mean anybody who is not willing to take a chance that he may require a second operation with partial wrist fusions or denervation operations. And PRC is our favorite because it gives a very quick result. It has the least complication rate and the long-term outcome have been very good. Thank you very much.
Okay, thank you, Praveen sir. Next would be a talk by Dr. Altaf Warid on limited wrist fusion, when and how.
Thank you, Dr. Karan. And thank you, Dr. Praveen, for the wonderful talk. Actually, I cannot share my screen. I think you have to stop sharing. Yeah. So even PRC is one of my favorite surgeries, and Dr. Praveen knows that I have learned it from him when I was in a fellowship in Ganga Hospital, and
you have written a paper also,
and
so
also we could manage to publish one paper on that. But I am here to talk on limited wrist fusion as Dr. Karan has advised. Hello? So I think Dr. Praveen has made my life a little bit easy because the indications for limited wrist fusion and proximal row carpectomy more or less are same. So the first part of the question, when is relatively has been answered, I think. So I'll start my talk. So basically the goal of this procedure is to maximize the wrist motion and strength while minimizing or eliminating the pain. So all of us know that the main goal in the Keinbock disease is to stop the progression of the disease and at the same time preserve the motion and also eliminate the pain to whatever extent it's possible. A little bit of background about scaphocapitate fusion. Actually, it was in Sutro in 1946 described this procedure of scaphocapitate arthrodesis as a treatment for scaphoid non-union, basically. And then subsequently it changed, and now it is one of the form. It's like a carpal force transmission is modified to offload lunate with a carpal alignment preservation that prevents the rotatory subluxation of the scaphoid. I think that's the key here, that one is that the lunate is offloaded and the alignment of the rest of the carpal bones is preserved. so that the rotatory subluxation of the scaphoid does not happen, like Dr. Ahire had said in his talk, that what happens to the scaphoid gets rotated ultimately when the carpal collapses. So to prevent that thing from happening and preserving the scaphoid is so when is the first question is stage 3A and 3B, as Dr. Praveen has said, that is, most of the times we always see our patients coming presenting in stage 3A or 3B. I think stage 4 is not a good idea to do a limited risk fusion, and I'm particularly talking about a scaphocapitate fusion here. So stage 3 and stage B, 3A and 3B are the ideal indications. Uh, there is a lot of literature again if you go on the net and see about scaphocapitate fusion, and this particular article was published in 2015, although most of the articles of this limited risk arthrodesis are small. They have a small sample size, 15, 20, at the most 25. A larger study although is required, but whatever articles we find, they are of a smaller sample size. So they all of them do suggest it does reduce pain scores and maintains wrist range of motion to good extent. And this particular is a recent article of 2020. Uh, so scaphocapitate fusion for advanced Keinbock disease maintains wrist motion and significantly reduces pain. Lunate excision is not necessary. PRC is still an option when radius and capitate articular surfaces are free of chondral lesions. So again, wherever we try to find out literature, PRC is always in comparison, the results are comparable to the limited wrist fusion. So regarding how, I'll try to show one operative video quickly because we have less time. So this particular case is a 46-year-old male, had symptoms since 1 year, and this was stage 3B. So I'll quickly go through this video. So that is the dorsal incision centering over the Lister's tubercle. And after skin and subcutaneous incision, all of us know that the first thing we look for is the third extensor compartment, that is the extensor pollicis longus tendon. And we cut the retinaculum in along the direction of the EPL tendon. And then retracting the EPL radially and the fourth compartment on the ulnar side, then we mark the capsular incision in a U-shaped manner, maybe radially based or based on the ulnar side. What we call is as ligaments preserving capsulotomy, explained by Berger. So this is the marking of the capsule of the wrist joint, and with a sharp 15 number blade, we can incise the capsule. So that is the arthrotomy basically. And once we have that capsule elevated on one side, then yeah, so that you can see that's the flap of the capsule, which should be preserved till the end so that we can resuture it back. I usually put 1K wire into the lunate first to identify just under image intensifier. And once we have confirmed the lunate, that is the scapholunate ligament, which is cut again with a sharp knife. That is the interval between the scaphoid and the lunate. This is a 3.5 millimeter Shan screw, which is inserted into the lunate, because most of the times we excise the lunate before doing the scaphocapitate fusion. So one of the way, actually, the article which we were talking about, which we published in Indian Journal of Plastic Surgery, is how to do a proximal row carpectomy, the surgical tip. So this one way is we find it an easy way to put a Shan screw in each of the carpal bones, and then kind of enucleating it in one single piece rather than taking out in a piecemeal way. So that is the lunate, which has been detached by its surrounding ligaments. And you can see then after some dissection, there is you can take out in one single piece. And although there are some remnants, always sometimes we have to check for the volar remnants. Oh, I'm sorry. Yeah. So after excising the lunate, then we come to the that is the cartilage, remnant cartilage of the some part of the lunate, and then we try to correct the rotation of the scaphoid, and then we have to do an removing the articular cartilage of the capitate and the scaphoid. So that is cutting of the articular surface of the capitate here, and then similarly that is removing the cartilage, and similarly we take off a small wafer of the cartilage from the scaphoid surface, and then that is how you see the two edges, two surfaces, raw surfaces of the two bones, and then align them properly. And under image intensifier, then you can go for fixation of the fusion. You can use the K wires, or we can use Hubbard screws. So that is provisional fixation with the K wire, and then that is the final placement of the Hubbard screw. So that is one going from the distal pole of the scaphoid into the capitate, and then another is going into the from the proximal pole to the capitate. And after fixation, when we fix it with Herbert screws, we get a good stable fixation. One can check, all range of motions, varus, valgus, flexion, extension, and whole. Uh, it moves in one unit, and that is the capsule, which you should preserve till the end. And then that is you should suture back the capsule of the wrist joint, and then you suture that is the capsular closure, a good airtight closure of the capsule, and then you release the tendons between the third and fourth compartment, and then you can suture the retinaculum. So I'll quickly run through this, and that is the final. And this was the post-op picture. 1 year follow-up, and thank you.
Thank you, Dr. Warid.
Yeah, thank you, Karan. Thank you.
Comprehensive talk regarding limited wrist fusion. And so moving on, these were the established procedures that we do as management for Keinbock's disease. Now coming to the debates and controversies, whether they have a role or not. So we'll start off with vascularized bone grafting by Dr. Parag. So Dr. Parag can start sharing the screen.
Yeah, I thank Karan for giving me an opportunity. Uh, is my screen visible? Am I audible?
Yes, sir.
Okay, okay. So, thank you. So after understanding the role of proximal row carpectomy and limited carpal fusion, now I think we are moving towards little lesser complicated lunate like grade 2 or 3A lunate. My talk is to describe a procedure or to analyze the result or to know what is the literature supporting vascularized bone graft. I am going to cover this in my talk in 5 minutes. So 28-year-old female who had a painful wrist, and she was unable to load on wrist, and she had restricted wrist movements, and the duration of symptoms were 7 months. So if you see the range of motion that she had was hardly 20-degree extension and hardly 20-degree flexion. If you analyze the X-ray, there was a ring sign in the scaphoid, and this was like grade 3A or 3B unit. But in such, I mean, sometimes we are also in a dilemma that the age of the patient is 28-year-old, a very, very young age, and X-ray radiologically the disease is definitely progressive, and this was the MRI. So I probably thought that this is a Lichman type 3A, and there is a fragmentation of lunate, but probably scaphoid does not have a collapse. So carpal height is well maintained. So I chose this patient to consider a vascularized bone graft with radial shortening. So the options those were discussed with this, or the options those were discussed with this patient was to whether to save lunate and sacrifice lunate. But because the age is 28, we had considered option of a vascularized bone graft. First, I would like to explain the technical details of this procedure. Usually, we prefer a curvilinear incision in between fourth and fifth extensor compartment. The reason being, we can extend the incision in the way in which we want to, as per the requirement, and the it is the procedure is called 4-5 intercompartmental vascularized bone graft. And so intercompartmental supraretinacular based vascularized bone graft. So what I am showing here is after retracting fourth and fifth extensor compartment, this is the vessel that we are seeing here, and that first we need to expose. And then after that once we see that this is the vessel, and from where this is the distal end of radius that we can harvest based on that particular vessel, as Dr. Pankaj showed before, that there is a bifurcation of this vessel, and we have to ligate the other end and take the bone graft from there. Now again, when we are doing this procedure, what I am showing here is a posterior introosseous nerve as well. So it has been proved in the literature also. Apart from this procedure, if you do a posterior introosseous nerve neurectomy, there is definitely very high chance or very good recovery, and patient gets a pain relief in a much better way. So this is the exactly the bifurcation of the vessel of the fourth and fifth extensor compartment, and we are going to take a bone graft from here after ligating this part of the vessel. So this is the bone graft harvest, and then after that we have to make a we have to make a entry point into the lunate, or we have to make a proper curating the lunate, and then this radial, I mean the bone graft that has been harvested, that we can put it in inside the curated lunate. And usually it sits very well. There is enough place to keep the that small piece of bone graft. Some people prefer to release a tourniquet and make sure that the vessel that is accompanying or that is along with the bone is having a profuse bleeding or adequate bleeding. I do not usually release my tourniquet during my procedure. And this is the radiological Shyam image from where we have taken a bone graft, and that bone graft has been inserted into the lunate. And after that we considered a 2 millimeter radial shortening at a diaphyseal level. I usually follow the same principle and protocol as Dr. Pankaj Ahire showed in his talk. And this was the pre-op picture of the wrist movement restriction and follow up at 8 months. In my opinion, usually the lunate looks more or less sometimes same as it was looking in the pre-op x-ray, but symptomatically patient definitely gets benefit. Now this is about this technical result. Now, what my literature says is vascularized bone graft for the Keinbock's disease. There are usually 3-4 types of vascularized bone graft they have described. First, which I have shown as a 4-5 ICSRA. Some people have done 1-2 ICSRA. Some people have done Pisiform vascularized bone graft. But definitely, as per this literature, at 19 months post surgery, the fragmentation of the lunate, they have mentioned that it has been healed and there is no donor site morbidity. But yes, these procedures are technically definitely challenging. Second article which is showing that whether vascularized bone graft has to be associated or combined with radiological shortening or not. So this article, which was published in 2013, it's a retrospective level 3 study where 5 years follow, and they had done combined procedure in which the conclusion was 75% had satisfactory outcome in only radial shortening, but 100% result or satisfactory outcome was seen in the patient where both the procedures were combined. Now the procedure that I added in my technique, like apart from a 4-5 vascular bone graft with the radial shortening, is wrist denervation procedure. So again, as per this article, 61 patient study and 47 patients had undergone wrist denervation, partial and total. I usually do not do any total wrist denervation. The only posterior interosseous nerve which is just nearby to our working area, that's why we find it very very easily, and I usually cut that nerve, and that gives definitely a good pain relief. So thank you very much. This was regarding the my vascularized bone graft analysis and technical tips on Keinbock's disease. I thank Dr. Karan for giving me that opportunity. I am very happy to answer the questions if there are any.
Thank you, Parag sir. We would be taking questions in the end. So if there are any questions, we can write it on the chat box amongst each other if you want to ask, or we can take questions. So now we will move on to a less commonly done procedure, the radial co-decompression. So that would be taken by Dr. Praveen sir. So Praveen sir can start sharing the screen again. Praveen sir, I think. Hello.
Hello, I'm audible now?
Yeah,
Yes.
you're audible now, sir.
Okay. Yes, good evening again. Today I'll be talking about radius core decompression, and I'm very happy to present this because this is the first time I am talking about this topic, and I'm sure many of the people would not have heard about this operation because it is something which we started doing 1 year back. And it is quite a fascinating thing because it gives very good and quick outcomes. So I will share our experience. We have operated 6 cases of radius core decompression till now, but it has a specific indication which I'm going to stress now. Now, what is radius core decompression? So this procedure was described by Ahire in 2003 and initially published in 2001, but later on he published the technique in detail in 2 years later. The procedure basically means that you are making a window in the metaphyseal area and totally scooping off all the bone in the metaphyseal area and pushing it on the sides. So you are creating a hollow metaphyseal area at the just underneath the lunate area. So what it does is, so it increases the blood circulation of the lunate and it allows it to get revascularized again. So the pain gets relieved. So it is interesting to know that how this Ahire got this idea. So his paper says that he had a patient of Keinbock's disease, which he was following and planning for surgery. But During that time, the patient developed a radius fracture. And he, to his surprise, when the radius fracture healed, the Keinbock's pain also went off and the patient never required a Keinbock surgery. So it was a chance discovery, and after that he started doing this operation. And his initial papers was a result almost of 10 years result, and it didn't have no case failed, and all the patient had a perfect pain relief and good range of movement. Recently, in 2017, also one more paper has come up which says 13 years follow-up of radius core decompression. And this again says the results were very good. But important thing to note is all these patients are less than 3A. So that is a tough thing about it, because 70% of our patients at presentation itself, they are beyond 3A. So first itself, it becomes a very uncommon indication in Keinbock's disease. And why I like this operation is because it gives such a beautiful range of movement. And this is the range of movement what you achieve at just maybe 2 or 3 months after the surgery. And it is maintained over a period of time. How this idea came when we started doing this 1 year back. So I had a chance of writing a literature review about Keinbock's disease treatment option in JHS. And in that, we saw that so many treatment options are described, but actually nobody knows why that treatment we are doing and what is the expected outcome, why that procedure is working. And if you see some systematic reviews, you will find that regardless of the type of treatment which has been described, let it be vascularized graft, let it be osteotomy, let it be arthroscopy, let it be arthroscopic pinning, all authors say that the result is nice. And this was a good article by Innis. He found that when he evaluated all the treatment options, he found that none is superior to other, and most of the treatment options are giving good results. Even there are nice paper on conservative treatment outcomes. There are no papers showing 30 years follow-up of any surgical option, but conservative treatment 30-year follow-up showed that 15 of the 16 patients were good. So that means you really should not force these Keinbock patients for surgery. And more importantly, what he noted that whichever patient persisted to have symptoms, it is better to intervene in them, and any intervention resulted good outcome. One common thing about all the good outcomes was there was something done to the radius. So there was hole drilled, osteotomy done, plate put, anything intervened to the radius is said to improve the blood circulation and relieves the pain and improves the vascularity of unit. So why not simpler the better, we know, and so why not do the simplest option to a patient who is eligible for this procedure. The best part of the operation is it doesn't burn any bridge. So whatever options we discussed about proximal row carpectomy, partial wrist fusions, anything can be done later. So it fits very well in our protocol. So whichever patient presents at less than 3A stage and who is having an ulnar positive or neutral variance, we offer them core decompression. Because this is the group which is not ideal for doing a radius shortening, and it is not required to do a PRC. This is a very simple operation and it preserves all the later options to us in case the operation does not work well. But to our surprise, 6 patients which we have done in 1 year, none of them are having pain and all of them are quite comfortable. Coming to the procedure as such, procedure is quite simple. And this is the typical indication, stage 3A Keinbock in a young 28-year-old lady who was a nurse, pain for 6 months. And this lady being from a medical profession, and we explained to her, and she was quite okay with a procedure like core decompression, which does not do too much of disturbance and keeps all the future options available. And this is how the procedure is done. You make a metaphyseal window. This part of the cortical bone is removed and it can be replaced back again. And this is the void created inside the metaphysis by a scoop pushing all the bones on the sides here and making the whole metaphysis empty to stress on the area which is under the lunate, because this is the area which is supposed to increase the blood circulation of the lunate. So procedure is something like that. So we create a holo in the metaphysis here. The original technique, they go through a lateral window, but somehow we feel like going in line with the lunate could be better, because you are able to have an area which is going to be directly in line with the lunate, and emptying this area becomes much easier. And also when you are approaching here, you can do a PIN neurectomy, which, as Parag told, could add to the pain relief what we get in this patient. And after you have scooped off all the bone in the metaphysis, mind it, we are not removing the bone, we are just scooping and putting it on sides. And we have always added something more. So this patient, actually, we put a scaphocapitate pins to allow better revascularization of the lunate. And then the cortical window is replaced back. And this is the outcome what you get. This patient, this is the outcome at 1 year, but at 3 months also patient had same amount of range of movement, because we have not opened the joint capsule and we have not interfered with any carpal bones. So naturally the range of movement is going to be very good. And this is the pre-op X-ray of this patient, and this is the post-op X-ray. If you compare the two, actually in 1 year, there is no change in the lunate as far as collapse is concerned. There is no further collapse. The scaphoid remains same oriented. One positive thing what we could see is there was a cavity inside the lunate over there, which seems to be filling up. The lunate looks little more dense. And in the later view, again, it looks little bit more dense here. The cavity which was present in lunate is gone, and there is no further collapse. So in 1 year, when the patient is using the hand comfortably, if there is no collapse, that is a good news. So recently, a 13-year follow-up of this procedure has been described, and the results have been uniformly good till 3A stage. They have extended the indication to 3B and 4, but they have found that in those patients, the result, they had 2 failures. So that is the reason why we strictly put it for patients who are less than 3A stages. And this very same patient at 1 year follow-up, not that the lunate is becoming better, pain is decreased, and because of decrease in pain, we have a perfect objective assessment. You see the grip strength, which was 8 preoperatively, have gone to 18 now, and she is doing quite well. This is another one patient who sent videos by WhatsApp, and this was operated. This was the second case, and she is actually doing quite well, and has got good range of movement, and there is no pain at all. So to summarize, the core decompression of the radius fits very well into stage 2 and 3A patients who are not ideal for doing a radius shortening. I am saying that again because still biomechanically it appears like radial shortening is good whenever ulnar negative variance is there, because you are offloading the lunate. It has been proved that core decompression of radius does not offload the lunate, but it only increases the vascularity of the lunate. They have done a dye studies, and they have found that vascularity of lunate is improved. So it is not an offloading procedure, it is a revascularization procedure. But good thing is you are not opening the joint, you are not putting any much implants there, and hence you will get a very quick recovery and a very good range of movement like this. And so you will really find that this procedure could very easily fit into the treatment regime, because it is really easy one and very nice for the patient and very nice for the surgeons as well. Thank you very much.
Thank you, Praveen, sir. We are running a little late. Request to faculty to please stay in the limit of time for the next topic. We would now go on to vascularized pisiform transfer. This procedure was described by Safar et al. In 2010, after which it has gained much popularity. So Dr. Vijay from Pune is doing this procedure in Keinbock disease. So he would now share with us his experience, technical tips and tricks, and whether it works or not. So over to Dr. Vijay.
Just a moment. Is it visible? I am audible?
Yes, voice is a bit breaking, but it is audible. You can continue.
Yeah. So, thank you, Karan, for giving me opportunity to talk this very controversial topic about vascular pisiform transfer. So, vascular pisiform transfer suffers procedure, and I am very what you say fortunate to do this procedure with Safar. So this is his own procedure. I was assisting him. So what is the aim? The aim is to decrease the pain. Is the first aim by keeping the mobility, to replace the dead bone, to maintain the distance between scaphoid and tricuspid.
Dr. Vijay, we cannot see your screen. The cursor in the center, the circular cursor is in the center. Can you, make it run the screen?
Which one? Resume to share. Okay. Now it is seen. Hello.
We cannot hear you.
Hello.
Yeah. Okay.
Hello.
Yeah, you can continue.
Continue. Okay. The screen is visible.
Yeah, screen is visible. Now you can continue. Now it is not.
Okay. And fourth one is the prevent the carpet collapse. So what are the indications? Indications for pisiform transfer is ligament stage 3A and 3B, preferably under 45 years of age, and manual worker may benefit more by this pisiform.
Dr. Vijay, we cannot see your presentation on the screen. Are you able to see your presentation on your screen?
Yes, yes.
Because we are not able to see at all. Is anybody else able to see?
No, sir. We are
No,
not
sir.
Yeah,
No.
if not, while Vijay technically fixes his
we can move on to the next topic of
transmission,
our
we can come back to this. Yeah.
So Dr. Amit can start presenting the arthroscopic part, which is the most interesting. We have kept it at the end. So
Yeah,
over to Dr.
Vijay,
Amit.
can you just ensure that your video or presentation is running on your screen smoothly, and then you can start sharing the screen.
Okay, so shall I start, Karan?
Yes, sir. Yes, sir.
Okay, so thank you, Karan, for inviting me for this webinar. I'll share the screen. Yeah, can you see the screen?
Yes, sir. You can continue. Yes.
Okay.
Clearly, we can hear you clearly also.
Yeah. So I'll be talking on role of wrist arthroscopy in Keinbock disease. So until now, we have seen the treatment algorithm based on Richmond's classification. According to this classification, stage 3 is very important. It decides whether we are going to save the lunate or we are going to excise it. According to this paper by Professor Gilberman and Martin Boyer, they have some important observations that differentiation of patients with stage 3A and 3B disease may be more difficult on X-ray. It is based on flexion of the scaphoid. and presence of cortical ring sign may not be a reliable indicator. Use of radioscaphoid angle increases the inter-observer reliability. So, Professor Greg Bain, in his landmark paper of 2006, came with this concept and classification based on the number of non-functioning articular surfaces, whether it is a distal radial surface, proximal lunate, distal lunate, and proximal capitate surface. We'll see this. So, according to him, in early stage of the Keinbock's disease, the surface should be normal glistening, like in this case. Now we are in the radiocarpal space, and we are seeing the scaphoid and radiocarpal ligaments and scaphoid fossa. As we go on ulnar side, we will view this is the lunate fossa and the proximal surface of the lunate, which is very glistening with some fibrillation, and this can be considered as a very early stage Keinbock disease. And here we can in such cases we should save the lunate. So when patient presents late, like this in this case of Keinbock's disease, the articular surface is damaged or sometimes it is floating. So here, if we see arthroscopically, so this is the floating articular surface of the proximal lunate. I'm moving it with the probe. Now you all can appreciate. And in such cases, we should go for some salvage surgeries. And Professor Bain has also mentioned about the about seeing the quality of the subchondral bone. Like this, in this case, here the surface is good, but we should see the subchondral bone, whether it is hard or soft. It can be done by palpating with the probe. Hard, if the surface is hard, it means that the lunate is in very early stage and we can save it. If it is soft, then it is going towards the advanced stages and fragmentation. So aim of arthroscopy for Keinbock's patient is basically to do debridement and to identify the best surgical reconstructive procedure. We'll see by example. This 49-year-old lady had a 2-year-old malunated distal radius, and she presented with pain since 8 to 9 months. If you see the X-ray carefully, so lunate looks like in early stage, and the radioscaphoid angle is also more than 60 degree. So we might consider saving this lunate radiologically, but we did midcarpal scopy through the midcarpal radial portal. The superior one is the capitate articular surface, and right bang on we are on the lunate, and we see this is the distal articular surface of the lunate, which is fragmented and collapsed. So in such cases, when the distal surface is non-functional, we should not save the lunate. So we proceeded with proximal row carpectomy. So Professor Bain in his paper clearly mentioned his treatment algorithm. In grade 0, when all the surfaces are good, he has advised extra articular procedure in the form of radial or capitate shortening, depending upon the variance. And in grade 1, when the proximal lunate surface is non-functional, he has advised proximal row carpectomy. Grade 2, basically along with the proximal lunate surface, the distal lunate fossa has non-functional articular surface. So we can, he has advised radioscapholunate fusion. And in stage 2B, when there are some linear fractures in the lunate, so proximal row carpectomy can be done. In advanced stages, when there are involvement of 3 or more surfaces, then we have to definitely go for salvage surgeries in the form of total wrist fusion or arthroplasty. So again, Professor Bain in came out with a new algorithm of 21st century. In this, they have considered three things: osseous, vascular, and cartilaginous. The discussion is out of scope. Discussion of this is out of scope of this talk. But I just wanted to mention that the status of the cartilage is also one very important part when the in the decision making, which has been clearly mentioned in this classification. Thank you very much.
Thank you, Dr. Amit. That was quite clear. The Greg Bain classification, basically, who's from Adelaide, has published regarding the classification based on arthroscopy. So now more and more, as hand is becoming a popular specialty, more and more surgeons are learning the technique of arthroscopy and assessment of the radiocarpal and the radiolunate joint. So that way, it is coming up in a big way. Okay, now moving on with the next topic. Vijay sir can start sharing his screen. We would go ahead with his talk. Over to Vijay sir.
Yeah, now it is visible.
Yes.
Hello.
Yes, yes.
It's visible, no?
It is visible.
Yes,
Yeah.
yes, yes, very much. Right.
Okay.
Yeah.
Right. It's visible, Praveen sir.
Yes, good.
Yes. Good. Okay. I will not turn on the video. The internet quality is not so good, so that's why I'm not make on the video. So this is vascular pisiform transfer. I mean, this is SAFAR procedure, and I was fortunate to work with him and learn this procedure. So the aim is to decrease the pain by keeping the mobility, to replace the dead bone, to maintain the distance between scaphoid and tricotrum and radius and capitate, and prevent the carpal collapse. So what are the indications for SAFAR procedure is Leishman stage 3 and 3B, not 4, not 2, not 1. Under age, preferably young age, and manual worker may benefit by this procedure. So if you compare the size of the lunate with a pisiform, so pisiform has got 11 size and lunate has 10. So it's comparably matching the size height-wise. Width-wise, pisiform is less and the lunate is more. So what are the pedicle it has been taken? There are the three pedicles. One is upper pedicle, which is oblique dorsal carpal artery, from which this pisiform, vascular pisiform is harvested. Then Beck has used a deep palmar branch of the ulnar artery and lateral pedicle. So this artery supply of the pisiform bone comes from three pedicles. This pisiform artery, which is originated from 4 centimeter proximal to the proximal crease of the wrist. So on the dissection, it is 6 centimeter from the pisiform bone. And if the this arrow is showing the dorsal oblique artery, from this is the pedicle for the pisiform transfer. So this is a video when it is harvested pisiform. So we just go into the cases. This is the first case I have operated. 54-year-old lady, right hand dominant, pain in left wrist since 8 months, restricted movement, grip strength was less but not measured. So this is the type stage 3A, which is operated on 2016. If you clearly seen that there is a sclerosis fragmentation of the lunate. So we did vascular pisiform transfer in this patient, and this is the 2-year result. If you see, there is a good alignment of the carpus. There is no decrease in space. This is after 2 years. And this is the range of motion at 2018. Good dorsiflexion. This patient doesn't do any physiotherapy. He doesn't come for a follow-up. It is very headache for me to get her into the clinic. But unfortunately, she came at 2018, and this is this last follow-up. After that, I have not followed. I have no follow-up of this patient. So this is second case. 19-year-old boy, right-handed, manual laborer, pain in the wrist since 1 year, right hand, stiffness and gross decrease in movement. This time I have measured the grip. it was 8 kg compared to the 30 kg on other side. This was the stage 3B, where the scaffold is rotated. Here, this is signet ring appearance is here. And we did scaphocapitate arthrodesis plus vascularized pisiform transfer for this patient, because we want to decrease the intercarpal pressure on the lunate. So this is a flexion pre-op 1 year and extension. It's quite 10 degree is more than pre-op, but if you see the grip strength, pre-operative it was 8 kg, at 6 months it was 12 kg, and after 1 year it was 18 kg, and grip strength was very good, no pain at all, and this is 1 year follow-up. If you see, this is a pisiform pre-op, and this is a this is a lunate pre-op, and this is the pisiform after 1 year. And if you see, this is the lunate, and after transmitted pisiform, you can see clearly the joint space here is maintained, the carpal height is maintained, so there is no collapse. And this patient doing the same work, he resumed the same employment after 1 year.
Vijay sir?
Yeah, I think it is stuck. Yeah, sorry. Yes. So we do radial shortening osteotomy to decrease the extracarpal hyperpressure, and scaphocapitate fusion to reduce the intercarpal hyperpressure when there is a radial ulnar variance and rotation of the scaphoid. So advantage of vascular pisiform transfer is the preserving the approximate normal structure of the wrist joint, restoring its motor function, reducing the pain, maintaining good grip, range of motion, and this procedure allows us to remain open for a limited fusion and PRC, because this patient has very young age. It is very 19-year-old, so he required secondary procedure. So limited fusion and PRC is open. So these are the references. Safar has got 15 years results. Then Dek has in 2005 has 10-year result, and Tan recently has published 15-year result. So thank you for your kind attention. Thank you very much. Any questions? I am ready to take questions.
So thank you, Dr. Vijay. We have now come to the end of the lecture session. So we know that in Keinbock we have seen the management, how the evolution of the concept has taken place in the last few decades. We have also seen the management, the standard procedure, how to do and when to do. Also the less commonly done procedures of vascularized bone grafting, radius co-decompression, vascularized pisiform, and arthroscopy, which has a good role in limited cases. So now all the lectures are over. So we are running a little late. So should we? So if there are any questions, we can take it up at this point of time by anyone. If someone wants to ask directly.
I have one question for Dr. Praveen. So
Yeah,
if you see a patient in stage 2 now, for example, so will you go for a core decompression or a radial shortening osteotomy? Like, what will be your procedure of choice if you see a patient in stage 2 or 3A for that matter?
Yeah. Actually, if the ulnar variance is negative, then radial shortening. If it is a neutral variance or positive variance, then core decompression. That is till the confidence in core decompression comes, but I am actually very pleasantly surprised with the outcome. Maybe it will change in some time.
Yeah. Can I ask a question?
Yeah.
Yeah, Dr. Amit Varade, do you do MRI for all the patients, or do you do arthroscopy for all the patients?
So MRI we do for the patients beyond stage 2, but most of the patients come to me late only. So you can say that I do MRI for all the cases. Then the arthroscopy part, arthroscopy I do for all the cases.
So as a diagnostic arthroscopy first, or diagnostic and therapeutic both? I mean,
yeah, therapeutic diagnostic arthroscopy first, because just to stage the lunate, whether we can salvage it or save it or not. And at the same time, in early stages, the advantage is we can do debridement, synovectomy, we can do radiocarbon.
okay.
I have a question. So may I ask? So while any procedure like scaphocapitate fusion or this vascularized pisiform in which the lunate is excised, does it give rise to an ulnar translocation or any carpal instability because of the long and short radial lunate ligaments attached? Yes, sir.
So ulnar translocation in PRC, if you say, the ulnar translocation will not happen if you preserve the ligament. But once you have excised the lunate, the ulnar translocation is almost universal. It will happen unless you have put something inside which is going to hold it so nicely, like vascularized pisiform or pyrocarbon. It would happen. But one way to prevent that is, as Warid, when he was presenting about scaphocapitate fusion. So suppose you're doing scaphocapitate fusion, if the lunate is not fractured and fragmented, it is suggested in a big Mayo paper, which actually compares all the techniques. They say if it is not fragmented and fractured, you don't remove the lunate. You just extend the scaphoid, the lunate will be offloaded, and that will prevent ulnar translocation. Because if lunate is completely removed, surely you will have ulnar translocation of the scaphoid. Second way of decreasing that is not to excise the whole lunate. Keep the volar shell intact, which will maintain the ligaments and will prevent the ulnar translocation. But whichever scaphocapitate fusion I have done where lunate is removed, all the scaphoids have translated down. Surprisingly, I got confused. This patient, I removed the lunate, the scaphoid has almost come to the lunate place.
Yes, sir.
I have one last practical question to Dr. Pankaj Ahire. Suppose we see lunate 3A Keinbock's disease in any patient and we advise surgery, and we have seen here is X-ray and MRI. And if this patient comes to us after 6 months of our opinion, will you repeat the MRI, or you will, based on the previous MRI, will you advise the treatment?
The role of MRI would be before stage 2 for confirmation of diagnosis, after stage 2 to look at the articular cartilage. Typically, the MRI will not alter my change of plan if I have already seen it around 6 months ago. There is a reason why I say what I am saying. So pain in Keinbock's disease would be because of two reasons. One is the avascular necrosis of a bone, which is kind of a non-mechanical pain which is at rest, which is continuous. And second, pain because of mechanical reasons like wearing out of the cartilage, scaphoid rotation, radioscaphoid impingement, causing pain on motion, restriction of movement. So once you have actually figured out what is the predominant cause of pain in the patient, the MRI is typically not going to change the treatment much.
Okay.
Problem is, if you are worried that you want to offer patient a PRC and you might find that the capitate articular cartilage is not good, and you want to take that decision beforehand, yes, either an MRI or a diagnostic arthroscopy would help. Or you actually want to look at the lunate articular cartilage before you talk to the patient, then MRI would help. Otherwise, there are options to change over your treatments intraoperatively, as Praveen has said. You plan your surgeries in such a way that you do not burn the bridges right in the beginning of the surgery. I would typically not do an MRI if I see a patient 6 months apart.
Okay. Thank you. Thank you.
One question I want to ask to Pankaj sir.
Yes.
Have you ever done osteotomy at metaphyseal level?
Never.
Oh.
For
Actually, I'm thinking since it is a metaphyseal bone, it will unite nicely because in one of my patient there was problem of non-union.
So diaphyseal osteotomy gives better control over rotation. There is matching surfaces which can be compressed. Metaphyseal osteotomy, when you do, you will have two non-matching surfaces to fix. You have a surface which is curved, so you require anatomical plates. So it just adds a few more dimensions. Obviously, if you take care of those dimensions, you can put a matching result. I'm much happier doing shaft osteotomy. Also, ever since I started doing the vascularized bone grafting, I'm much happier not to disturb the metaphysis and do an osteotomy in the diaphysis.
What is your experience, sir?
I did sometime this metaphyseal level osteotomy, but as Pankaj sir told, getting a circumferential shortening to get a perfect apposition is difficult in metaphyseal area.
Oh.
Though the fixation comes nice and you are seeing, but if you see them carefully, it may be a little bit opened up on the dorsum and you may tilt the radius distal articular surface. But diaphyseal osteotomy is so nice, easy, and it comes perfectly. Because in metaphyseus, a circumferential view is not that nice. Why we did is we thought that it will improve the vascularity better.
That is
and
my point.
a nice locking plate will allow immediate mobilization. That's what I thought. It worked very well, but there was a slight concern that it is tilting the distal radius. So metaphyseal radius shaft is quite easy and nice and works well.
Okay.
Sorry,
yes, sir.
go ahead.
Yes, sir, please.
No, go ahead. If there's a question, that is a priority. Comments can wait.
So, sir, age, is age a factor in general for considering revascularization? If the patient has a medical comorbidity, does it change your decision for doing a revascularization?
If I were to answer this question, no.
Yes, sir.
I would, depending on the factors which guide the treatment, I might offer the same treatment for a 20-year-old that I might offer to a 40-year-old. Yes, when it comes to 60-year plus with low demand patient, wrist denervation will weigh very heavily on my mind if the patient is presenting late. Otherwise, for anybody else, I don't think I would hesitate. I would not hesitate doing a PRC in a 20-year-old.
Okay. Sir, I have one question for Praveen, sir. Like the Peterston paper of doing PRC in 40-year plus patients is the results are good. But sir, in like 20 years or then adolescent patients, if they come in for Keinbock, then still, sir, you would consider PRC, sir? Or
previously, because of those papers, we used to worry and to feel bit shy to tell everyone that we are doing PRC. But if you see the recent papers by Mayo Group, in relatively younger, 30 years, they've put a paper. But youngest we have done till now is 24. And that patient is now 6 years post-surgery and there is no pain at all. And for me now, age is no bar.
Yes, sir.
And if young patient, old patient, it is okay, we can do. Proximal row carpectomy, youngest we had done 24, but I think age is not really a problem. But recently we had two boys who are 17 years. So in them, I felt a little bit that maybe PRC, I don't know whether it will work. So in them, we have done actually only lunate excision and a ligament reconstruction to prevent flexion of the scaphoid. Same like what we do for scapholunate ligament injuries. So that is some new procedure what we have done. And in short term, both of them are doing quite well. So maybe in another 2 years or so, I will present their follow-up.
Yes, sir.
Yeah, and coming to the point of ulnar translocation, Praveen. So you mentioned about translocation when you did scaphocapitate fusion. Is that right?
Yeah.
Now, when you are leaving a scaphoid bone, which does not have the stopper of the lunate over there, you are creating a potential. There is a potential space available, and a scaphoid which can migrate, because there is nothing to hold the scaphoid up except that it is attached to the capitate now, which itself is floating. So this is a situation of potential instability with respect to the radius. The carpus is in an unstable situation, and it has to find a stable position somewhere. Doing so, it is going to migrate. I have personally never done a scaphocapitate fusion, so I really cannot vouch for this. But if you see our PRC patients, and all of us have got very long follow-ups of PRC patients, at least 15 years, 10 years plus, I have not seen them migrate towards the ulna. That is what that translocation is what I would be more worried about. And as long as, I think in your talk you mentioned, as long as we have taken care to preserve the radioscaphocapitate ligament, I don't think we see I have not seen ulnar translocation of the capitate.
Correct.
Yeah.
Translocation, I have also not seen. I think he was asking about scaphoid translocation only.
Oh, I'm sorry. Then I think I misread the question. I'm sorry.
Translocation. And actually, as you are telling, no, it is very amazing, because many of these patients have ulnar negative variants. So you mentally feel that this capitate is going to slide and come onto the ulnar side, because there is a slant like that, but it does not come. So that is quite interesting. And I think the ligament is the key. If you are holding the ligament in correct position, it is going to remain there. And scaphoid translocates.
I would like to make a point there, because I think we have done maybe around 15 cases of scaphocapitate fusion in last 4 years. And I think in 80% of the patients, we have seen ulnar translocation of the scaphoid. Sometimes it looks like there's an scapholunate coalition. The X-ray looks like it's a single bone. So it glides throughout the articular surface. But surprisingly, they also have pretty decent range of motion. But we don't have the long-term follow-up of that. That is just 1 or 2 years follow-up.
The Mayo group only, they compared these two, removing lunate or not removing lunate. Whenever they have not removed the lunate, they found that there was no translation of the scaphoid. But again, not removing the lunate is only possible when it is not fragmented. If it is fragmented, then you are concerned that it is going to be a source of pain. And as Dr. Pankaj also was mentioning, one part of the pain is avascularity. So you always worry that it is going to cause pain. But surprisingly, they found that they actually mentioned in paper that the pain is because of microfractures only. And once you offload the lunate, there are no microfractures and there won't be any pain. We have left the lunate for 2 patients in which the lunate was not fragmented out of maybe 8 scaphocapitate fusions what we have done. In these 2 patients, we didn't remove the lunate, and both of them actually doing quite well. One of them was done by Dr. Anthony Berger in our live surgery course, and second one I did, and both of them are okay. But still I am apprehensive about what, as Dr. Pankaj was telling. Yes, sir.
Yeah, so a large part of the avascular necrosis knowledge that we have has come from the hip, both adult as well as adolescent of the Perthes disease. And in the adult hip, typically the avascular necrosis arthritis that develops, typically there is not much destruction in the head. The neck part is still intact. And there was always a temptation whether a surface replacement would work for these patients. Okay. But surface replacement was contraindicated for these patients in the hip, because you are potentially leaving an avascular bone behind, which itself could be the source of pain and not only the secondary arthritis. Similarly, while we are doing a procedure for secondary effects of lunatomalacia, leaving an avascular bone behind, which itself could be source of pain, could be a potential downfall. However, if you see why anything that we do intra-articularly reduces wrist pain, eventually, I think when we are doing the capsulotomies, we are causing some amount of denervation, some amount of neovascularization that is happening because of the trauma that we are inflicting. That may be causing reduction of pain. So key would be when we start doing these procedures.
Session, there are no case presentations because we are already running.
So no problem. We are running late. So I'll just wind up very quickly.
Yes, sir.
So when we start doing the same procedure that we are doing now with open arthrotomy, now arthroscopically, that would be an interesting thing to compare whether we are able to produce the same level of pain reduction that we normally would get. Say, for example, an arthroscopic PRC or an arthroscopic scaphocapitate fusion. That would be something to compare with. And then we would know whether it is what we are doing to the bone is causing pain relief or what we are doing to the capsule is causing pain relief.
Sir, I have one comment. I also, sir, have following Tony Berger's what sir showed that leaving behind the lunate. Sir, essentially the pain goes away, but then the range of motion is still the same. There is no improvement in the range of motion just because that lunate articular surface is still rubbing against this thing. But the pain goes away, sir. If there is arthritis, if there is some lunatomalacia in the distal radius lunate fossa or on the lunate, but then the range of motion doesn't improve. That is what is my experience. There is no translocation, there is no pain, only that the range of motion is not improving. That is the problem. Yes, sir.
Yeah. I think whenever we are dealing with conditions where we are trying to preserve the joint and we are trying to reduce pain, our priorities have to be very, very clear. Priority number 1 is pain reduction. Priority number 2 is a stable joint. Priority number 3 is range of movement. And priority number 4 is the joint length, bone length, limb length, whatever. As long as if your certain procedure is able to give you a predictable pain relief at the cost of the lower priority is absolutely fine.
Okay, sir. Sure.
This is how I think about this procedure because we are spoiled for choices here.
Yeah. Actually, the pain, as you are telling, the range of movement may not increase much. The mechanism, because in Keinbock's disease, actually the range is not so much restricted in most of the patients. Many of them actually move quite nicely. So the part of the restriction which is because of pain gets better. So maybe what pre-op range was there, it would add to 15-20 degree on either side.
True.
Right. Okay. Are there any more questions?
Lot of unanswered questions in mind though.
So may I ask all the faculty that now Dr. Karan in his presentation showed about the size of the shape of the lunate. Like the lunate has different shapes. How many times in our clinical practice we really, I personally, I know I am wrong, but I don't see the shape of the lunate to plan my treatment. Dr. Praveen, Dr. Pankaj, Amit, Dr. Karan, do you see that? Does it really matter?
Actually, we one of our fellow did morphological studies of all the Keinbock's patient what we had. Unfortunately, you cannot study the lunate because lunate is collapsed in 3B. But he studied all of the other parameters like there's a hamate process in a type 2 lunate and what is the height of the scaphoid and capitate height, all the things he studied. But I think it will make difference if you are going for those off-label treatments or like less label treatments. Like suppose you want to do a capitate shortening, then it is useful. But if you are doing a PRC, then nothing is required. You only have to remove everything.
So, but I got the answer now that yes, we mostly see advanced stage of the lunate. That time, definitely the shape of the lunate may not matter.
Correct. So if you are doing a procedure like a capitate shortening, then surely it will matter. But if you are doing a PRC or a radial shortening, then it will surely not matter. Though people have compared, initially what they were telling is people who have type 2 lunate, they have more conical capitate. And those conical capitate people are going to have poor result with PRC. That was a thought. But recently I read a paper which has compared the capitate shape with outcome of PRC, and conical, pointed, no difference. The outcome is the same, good outcome.
Sir, like with respect to the morphology, what I had seen like in Greg Bain's paper only, that inclination, what Dr. Amit Varade sir was also asking, whether he does a metaphysial. So metaphysial is just for improving the radial inclination. If you think that the lunate is slipping out and you want to like contain it, so at a very early stage, you can do a metaphysial osteotomy, do a plating, and just correct the inclination if you feel that the inclination is slightly here and there.
Yeah,
This
that's
is
what I
what,
meant.
yes,
If
sir.
you are doing
Other than that,
less, less not doing the common standard operation like PRC, radius shortening, then you have to see. But one very interesting observation what has been found is this type 2 lunate people will present late, because there the lunate collapse does not happen very quickly. So I think all that understanding disease, it is very interesting to know that, but when it comes to treatment, especially in advanced stages, it will not make much difference.
In your last 10-15 years of experience, have you seen any patient progressing from 1 to 2, 2 to 3A, 3 to 3B, and not opted for the treatment in 15 years follow?
Yes, three are there. So
3.
there are three patients are there.
And what was the
one,
duration of progression?
this one girl is an IT girl, and actually she used to be Tamil Nadu badminton player.
Okay.
And so for her, she meant is any surgery at the wrist is going to cause so much problem. But she was a player in that her very young age, and slowly she has been off playing. When she came, she had a stage 2, the lunate looking avascular but no collapse. And then we told, okay, we will follow up. Every 6 months, she did MRI for 2 years. There was no change at all. Another is a patient, a wife of a radiologist. She did a sequential MRIs, and actually there was no change. But pain comes and goes. There is no continuous pain, but sometimes pain is there. Then they put splint for a few days, the pain goes off. So there are three patients, very keenly I am following them up. And someday we'll know whether conservative treatment also works.
Thank you.
So, any more questions? If there are no more questions, we would conclude the session. So, any closing remarks by Praveen sir, Pankaj sir?
Okay, let Pankaj sir tell the last. So I will tell before that. So good, Karan. So you brought up a very interesting topic. We know that it is very close to our heart, but not many conferences you get an opportunity to have a session on Keinbock disease. So maybe this virtual meet was a very good time in which we can learn in detail all the small fine things, discuss about that. And it was a very healthy discussion. And Pankaj sir actually gave a very nice algorithm of management. It is very similar to what we do, and it further strengthens my belief in the algorithm what we do. Thank you.
Pankaj sir.
Yeah, thanks everyone. I would just say one thing. I think I'm very happy to hear from Praveen that there is one factor which helps prognosticate lunatomalacia that he mentioned, a type 2 lunate. I think most of the confusion or most of the indecision about lunatomalacia is because we do not know which ones are going to get worse and which are not going to get worse. If we are able to identify lunate at risk factors, just like everywhere the landmark papers have been to identify the the risk factors, say the spine at risk by Dr. Rajsekharan, or cateral staging to find the femoral head at risk. If you are able to actually say the fact that the lunate at risk factors, then we will be able to say which are the ones which we should observe and which are the ones we should aggressively uh, uh, treat. Till then, we'll continue discussing. Thank you very much. And
I have one question, last question for Praveen sir. Sir, if there is lunatomalacia of the radial surface and the capitate surface, then how do you go ahead in a collapsed lunate? So
actually, interestingly, theoretically, they say that the radius scaphoid surface and the lunate surface of radius is eroded. We studied consecutive 50 patients in whom we were doing PRC or partial wrist fusion. There was only one patient which had radial scaphoid surface involved, and that too not complete, only the dorsal part of it. So that is a very nice reason why we are discussing about biomechanics. So it is told that the scaphoid flexion in Keinbock is only pure flexion. There is no dorsal translation of the proximal part. So since it is within the normal range of movement of the scaphoid, it does not cause arthritis. But the scaphoid flexion in scapholunate problems is dorsal translation of the proximal pole, which will cause arthritis. So in Keinbock, it is very uncommon to find the scaphoid articular surface totally eroded. But even if it is eroded, capsular.
Sir, my question is, if the lunate surface of the radius is eroded as well as the capitate, so is the will a ligament, sorry, will a capsular interposition work in that case, PRC?
Yes, it will work. Actually, I thought you are asking the more difficult question.
So Praveen has put it on record now. That even if both articular surfaces are eroded, you put a capsule in between, it's going to work.
It will surely work.
Yeah.
Yeah.
Yes, sir. I thought only capitate surface is eroded, then only you can do capsular interposition. But I thought
capsular interposition for both, because it is interposing.
It is interposing
for both, but fortunately, I have not seen anybody having both involvement. The capitate is there, or capitate is there in all the scaphoid related problems, and the lunate fossa is there in Keinbock related problem. Both of them having a complete loss, never seen, but I would not hesitate to interpose the capsule.
Okay. So thank you, everyone. Thanks all faculty. Thanks to all the people who are attending this program right now. It was a great meet and a lot of intriguing, triggering questions were asked. So thank you for the excellent talks and presentations. So we'll stop the meeting, and so goodbye, everyone.
Okay.
Thanks, Karan.
Thank you.
Bye-bye.
Goodbye.
Praveen sir, Pankaj sir, Neeraj sir.
Bye.
Okay, bye. Amit.
Thank you, everyone.
Thank you.